the first thing that you need to do is sanitize and put gloves on, but then you will say, ah, yes, I am sanitizing my area with chlorhexidine or germicidal wipes. Okay, so before you set up for a bronch, you always sanitize your space, always. So, and you don't have to actually do it. You can just say, yes, I'm sanitizing. And then we take out sterile drapes. Here we are. Definitely, completely, totally sterile. And you are going to place the sterile drapes where you're going to be setting up all of your bronchoscopy equipment. So first, think of infection control. Sterilize your area, put down your sterile drapes. Then you're going to start setting up for the bronch, and you need to set up your patient. Now, I get asked a lot, which one do you want me to set up for first? I don't care. They both need to be set up. What order you set them up in is completely up to you and your comfort level. So if you want to set your patient up first, that's fine. If you want to set up for the bronch first and then your patient, that's fine as well. The patient will be undergoing, they're going to go through the mouth. So we have to make sure that we do place a bite block on the patient. So what I tell all of my students is everything that you need is in the bronch cart. If it's empty, then you're safe. So first of all, you actually would normally in the hospital, you're going to have 2 section setups. One section set up for your bronch, one section set up for the patient in case they vomit or they need to have their mouth sectioned. So, but this one, you want to make sure that you have your yonker set up and ready to go. I don't have the connector for this, otherwise we would have another setup here, but this will suffice. So then you're going to start just setting up for the bronch. So Bode adapter in case the patient has to be intubated. We have a Lucan strap. We usually use at least 2 or 3 of those per bronch. Our nebulizer and our duoneb with our albuterol, and then our anticholinergic, which is our Atrovent. And then lubricating jelly. You always need to lube your bronchoscope. Otherwise, it's the same reason why you would lube your catheter for NT sectioning, okay? So you always want to make sure that you have lube. And then here I have my BAL specimen and my other specimen bags, because everything that you get, you're going to end up putting it in a bag and taking it to the lab. Now here comes the kind of tricky part with the tools. So you're gonna have an array of tools in here, but which ones you choose is going to depend on what kind of patient you have. So let's go ahead and say that I have a patient who has a pneumonia and they're not responding to antibiotics, and they also have kind of like this suspicious dark spot on their bronchi, and we're not sure if that's a fungal growth or what. So in that instance, I would do a bronchial alveolar lavage, because remember, that's getting liquid lung back. So we're going to flush into the alveoli and pull back. And then I would also want to use a brush, so we can brush the area of the suspicious lesion. So since I know that I have that, I'm going to go ahead and put those tools here with my equipment, okay? Now, once I've done that, then you're just going to keep going through and setting up. I have epinephrine and I have lidocaine. So I usually put those in these little cups right here off to the side, and then they need to each have their own dedicated syringe. So I even labeled them for you. So we've got our lidocaine over here, epinephrine over here. Wet and dry specimen cups. Wet specimen cup, dry specimen cup. This also goes for your micro slides. So wet and dry specimen cup. And then I have my micro slides here. So you want to put out at least 6. I usually put out about 8, but you want to put out at least 6. So 1, 2, 3, 4, 5, and 6. And just be careful to not cut yourself with these. This is for his setup, so I'm going to put that off to the side. I'll deal with that later. And then we also want sterile gauze. You never know. Sometimes we have to wipe off the end of the scope. Sometimes we use it to catch things. So we always have a little bit of sterile gauze. All right, so that's empty. That's empty. Nice. Okay, so now we need a lot of saline. And when I say a lot of saline, I mean we use a lot of saline. So you always want to have the big container of it, okay? So some hospitals I've seen, they use those saline bags, like the IV bags, but everywhere I've worked, we've always used the bottles. So this is a large bottle of saline right here. And then the other thing that we want is large syringes. So See that? So if I'm doing a BAL and I need to push 40 mLs or 50 mLs, then this was gonna cut it. All right, so this is gonna give me that that amount. And then notice this one, I'm very proud of this, has little ice cubes in it. So that's for your iced saline. So we have one for regular saline and one for iced saline. So those are gonna both go right here. And I would put them in emesis basins so that way I can keep them in an area where they're clean. I would put sterile gauze down there just to make sure I'm keeping everything as sterile as possible. This is more patient setup, so I'm just gonna go ahead and put that over there because I've decided I'm gonna set up for my bronch first and I'll set up for my patient after. Now, the next thing is microslides. Remember, there's a dry and a wet microslide container, so you need to have both available just in case the physician wants it in the wet solution or if they want it to be kept dry. All right, so now I'm good there, so that's empty. And then my last one I see, I have my intubation kit. A lot of people forget this. Make sure you have 2 of everything for your PPE. 2 gowns, 2 masks, 2 sterile gloves, 2 eye protection. So you can put those here. I have my intubation kit right here. And then of course I have my ambu bag. So now I have set up everything, almost everything for my bronch. I haven't pulled my scope out yet, but we'll do that in a minute. I'm gonna set up for my patient next. So when you're setting up for your patient, you always want to put them on a nasal cannula or a mask or some form of oxygen. Even if they're not hypoxemic, they usually will be during the procedure because we're sedating them and we're putting a scope down their airway. So usually I start them on about 3 to 4 liters. And yes, you need to turn the cannula on, even though we know it's not real oxygen. I still want you guys to get in the habit of that. You don't ever want to be that person who says, I put the oxygen on them and their SpO2 never went up. They must have refractory hypoxemia. And then no, you just didn't turn on your Thorpe tube. That's always a real embarrassing one. So there we go. All right, so I'm gonna put his little oxygen on there. And then I'm gonna put his bite block in because remember, we're going through the mouth. So I don't want him to chomp down on my very expensive tube. So this has little hooks on the side that you can just hook this onto. You're just gonna pop that in their mouth. Fun fact, they do this while you're still awake. So usually they give you some Ativan, and then while they're doing the conscious sedation, they'll put the bite block in. So we're putting on the talking like this. So it's a little uncomfortable for a few minutes. There we go. All right, and then this is another kind of thing that I get a little anal about. Make sure that your blood pressure cuff is on the opposite side of where your pulse oximeter is. Does anybody know why I care about that? Why would that matter?
The blood flow. It'll kind of cut off the blood flow.
Exactly. So what'll happen is when that blood pressure cuff inflates and it goes, then I'm going to lose my pulsatile waveform on my pulse ox. And I don't want to lose that. I always want to have that. So then I'm going to put his little pulse ox on his finger. Oh, I think I just broke his finger. Sorry, buddy. So, and then I want you to do the 5-point tele lead. So all you got to do is use Le Google. I also put a video. It says 5-point tele lead for competency. But you just want to do the 5-point, and I'm not going to do the stickies because I'm working a little faster here, but it's going to look something like this. So this is pretty common for us to do the 5-point. I've heard sometimes in sublabs they use the 3-point, but for us we're going to use the 5-point. So, and there he is. Now he is all set up and he's ready. My bronch is all set up and ready. So now what's going to happen is you're going to say, okay, Miss P or Mr. Price, I'm all set up. I'm ready to go. So then I'm going to come over and I'm going to say, okay, so what did you have the patient sign before you started setting up all this beautiful equipment? What did you have them sign? Consent. Good job. What are you going to perform with the RN and the physician before you sedate the patient and begin the procedure? Time out, right? We want to make sure we're all on the same page with what we're doing and where we're going and what the plan is for the procedure. Then I'm going to say, how did you prepare the patient's airway for the procedure? So, yep, nebulize. You can say duoneb because that has albuterol and an anticholinergic, or you can just say nebulized ipratropium, either one. We always gave duoneb. So I would say I gave them a nebulized duoneb treatment, and then right after that, I gave them a nebulized lidocaine treatment. Okay, so this first, then the lidocaine second. Then once that's done, then I'll say, okay, so what did you check on your equipment? And that's where the lights, camera, action comes in. So this is where you might want to practice with this a little bit so you aren't fumbling too much for the competency. So this is a non-disposable fiber optic bronchoscope. And this is the source, the light source, and the power source right here. So I'm going to go ahead and plug this in. And you're going to say, I will check the lights on the bronchoscope to make sure it's working, because you can't find anything without light. I'm going to check through the eyepiece to make sure there are no occlusions. So that's the camera. You can also make sure the camera's working. And then action is your working channel and suction port. Now that you're going to have to verbalize, because my suction button is non-existent on here. So then I'm going to say, so when I say show me, you're going to take this part right here. And this goes on the top. This little tiny part right here goes in the bottom. You're going to plug it in. You're going to hear a click. That means it's plugged in. Now normally this is in a sterile sleeve, so I want to make sure I point that out. So then you're going to turn on this green button right here. That's going to make the light work. So you can just shine it down, make sure that the light is working. And then you're going to look through the eyepiece to make sure that you can see, and I can see all of you, through the eyepiece. So that's working, And then my suction button, which would normally be right here, it's not there. So you would just verbalize, yes, I checked the suction. This is the working channel right here. So, and then this is the flexion. So whoop, whoop, it's pretty cool. And then you can actually focus using this little ring right here. So, so you checked your equipment, and then I'm going to say, okay, so I see that you have a patient who needs a bronchial alveolar lavage. If you put down 60 mLs of saline, how much do you expect to get back? About half, right? So about 30 mLs. Now, what's a complication that can occur from those 30 mLs that are left behind? Hypoxemia. So that's another question. So we'll ask you a few questions that are specific to the case that you've been given. So in this instance, we would worry about hypoxemia. It's very common with bronchoalveolar lavage because remember, we're pushing down so much saline, but if we only get half back, the rest is still there. So it needs to get absorbed, but it's going to take a minute. So they can be hypoxemic. Now, if you have a patient who has a pulmonary nodule and you're going to be using the needle, the forceps, the brush, what do we need to worry about? Bleeding. So you want to make sure you have your ice saline and your epinephrine ready, okay? Now, the last question, I'll ask two questions, is how are you going to recover the patient in the recovery room? How are they going to sit? How long do they have to wait before they can have something by mouth?
Semi-Fowler's, MPO 4 hours.
Yep, semi-Fowler's, MPO 4 hours, or if sensation returns early, that's fine. But if it's like 30 minutes after and they're asking for applesauce, they're going to have to wait. So a semi or high Fowler's is fine. Either one, we just want them sitting up. MPO for 4 hours or until sensation returns. And I might also say, what are you going to do with your scope afterwards? Because you're in old school world, Miss P's world. So what are you going to do with that right afterwards? You're going to soak it. You don't have to say it right, but you're going to soak it in glutaraldehyde. You can say glutarhyde or whatever. You can just, but you're going to soak it overnight in glutaraldehyde. Okay, so that's what you need to do with the scope. And then that'll be it. So then, I'm sorry, Darlene, I told you were only going to move once, and now I'm going to make you move again. Then I'm going to say, all right, now you need to set up for conscious sedation. So your patient's pretty much already set up for conscious sedation. There are only a few things that we want to make sure that we do. So then I'm going to say, great, you're done. Now, thank you. Set your patient up for conscious sedation. All right, so what am I going to swap to here? I'm going to swap to an oxygen source with an end-tidal CO2 monitor attached to it, which we'll learn about this tomorrow, but this is a side stream device. It's an oxymask. So this is delivering the oxygen. This is taking samples of the breath for end-tidal CO2. So you're going to come on over here and you're going to take your patient off of their oxygen And I also have nasal cannulas that are side stream as well. So you might get a nasal cannula, you might get, and you can take this out as well. You might get a nasal cannula, you might get a mask, either one. As long as it delivers oxygen and measures their end-tidal CO2. All right, so there we go, there we go, he's all good. Oh, these fell off. There we go, fix that. All right. Okay, I'm monitoring his end-tidal CO2. I want to make sure I have an OPA and an MPA close by. And then my final thing is you put and this is actually from Loma Linda. They told me about this is something they do there and I like it, so I took it. Ooh, his head's really heavy. There we go. A towel under their head and make sure your yonker's right there. Why do you think I want a towel under their head and a yonker close by when we're consciously sedating them?
They cough. Doesn't roll back.
You are like right on the money. So if they cough, yes, or one of the most common side effects of morphine and fentanyl is vomiting. So you feel real good and then you barf. So if they puke, we want to have their head kind of positioned. Same thing with, right, we don't want them aspirating. So you were right there. If they puke, we want their head a little tiny bit forward and we want to make sure we have the yonker right there, okay, because we don't want them to aspirate. And that's it. So now you've set up for conscious sedation and that satisfies that portion of the competency. That's it. And this stuff will be off to the side. So literally I'm going to hand it to you and say, okay, now set your patient up for conscious sedation. So that's it. All right. Any questions? It's hot in here. They've got to fix this.